हेलो। Greetings from National Academy of Medical Sciences, India. Focusing on NAMS Vision 2030, NAMS is pleased to share some of the important activities like NAMS National, International Fellowship and Membership, Member After Day and AIIMS-NAMS, NAMS Task Forces, AIIMS-NAMS Navigate Medico CME, CME activities, publication of annals, newsletter, networking with professionals, public orations, Young Scientist Fellowship, Scientist Exchange Program, Scientist Professor and many more activities. All application forms for fellowship, membership, associate fellowship, and member after day NB have been made online and objective criteria from the year 2022. AIIMS has also started a new online AIIMS-NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app. Greetings from National Academy of Medical Sciences, India. Focusing on NAMS Vision 2030, NAMS is pleased to share some of the important activities like NAMS National, International Fellowship and Membership, Member After Day and AIIMS-NAMS, NAMS Task Forces, AIIMS-NAMS Navigate Medico CME, CME activities, publication of annals, newsletter, networking with professionals, public orations, Young Scientist Fellowship, Scientist Exchange Program, scientific visit of Emeritus Professor and many more activities. All application forms for fellowship, membership, associate fellowship, and member after day NB have been made online and objective criteria from the year 2022. AIIMS has also started a new online AIIMS-NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app. Greetings from National Academy of Medical Sciences, India. Focusing on NAMS Vision 2030, NAMS is pleased to share some of the important activities like NAMS National, International Fellowship and Membership, Member After Day and AIIMS-NAMS, NAMS Task Forces, AIIMS-NAMS Navigate Medico CME activities, publication of annals, newsletter, networking with professionals, public orations, Young Scientist Fellowship, Scientist Exchange Program, scientific visit of Emeritus Professor and many more activities. All application forms for fellowship, membership, associate fellowship, and member after day NB have been made online and objective criteria from the year 2022. NAMS has also started a new online AIIMS-NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app.
Hello, am I audible?
हेलो गुड आफ्टरनून सर।
मैम आप बोल रहे हैं प्रोफेसर मीनू?
हाँ जी
मैम
नमस्कार सर। कैसे हैं आप? सुनाई दे रहा है ठीक से?
जी मैम,
सुनाई दे रहा है ठीक से?
यस यस मैम, बिल्कुल सुनाई दे रहा है, एब्सोल्युटली फाइन।
तो जब मैं करूंगी तो मेरे को आपकी वो अनशेयर होगी प्रेजेंटेशन में चल रही है सर। ओके, तो आई विल शेयर माय प्रेजेंटेशन थोड़ा सा बाद में, ठीक है?
यस मैम,
इनिशियल पार्ट, हाँ जी ठीक है। तो वी आर ऑल सेट।
यस मैम।
Good afternoon. Nice to see you. Namaste, Kapil. Preeti, very nice. Ajay, very good. Today is an important day for us. Okay.
Maybe we can start.
Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint AIIMS-NAMS Navigate CME program from 1st September 2023 for postgraduate students in all the AIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on the first Friday of every month from 3 p.m. to 5 p.m. The AIIMS-NAMS CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medical CME is to help them to be more proficient in their profession. Each session will cover 2 topics. Each topic will be of 1 hour duration, which includes 45 minutes for presentation by speaker, 15 minutes for questions and answers. Thank you for your kind support.
Good afternoon, one and all. I welcome you all to today's Navigate Medico CME program. I would now like to invite Professor Umesh Kapil Sir, the Secretary of National Academy of Medical Sciences, to deliver the welcome address.
Namaskar and good evening to all the delegates, all the participants. My most heartiest welcome to Dr. Meenu Singh, AIIMS Rishikesh. I am really grateful to you for extending all the support to AIIMS Navigate program, AIIMS-NAMS Navigate program. It's an humble effort on the part of National Academy of Medical Sciences to undertake this CME activity. We would like to reach to the doctor at the remotest area of our country who are interested in improving their skills in the clinical related issues. We have been successful, although the amount of success which we expect is still to come. The program not only helps the students to update their knowledge, but also to clarify their queries. Because what we have done under this activity, we have undertaken the topics which are of common interest to the clinical, non-clinical, paraclinical, postgraduate students, and those who are preparing themselves for the post-examination. What we are doing is, we are putting up these live sessions on our NAMS website. It's a virtual library, and so that the students who have missed or students who want to clarify their doubts, they can look at the specific portion of the videos and get themselves updated. All the PowerPoint presentations are also uploaded and they can be freely downloaded so that it becomes, they can use it, they can utilize it for their benefit. Now, another important thing is that we are live telecasting them, all these sessions, the YouTube channel, and I must admit that all these sessions which have been done till date, they have been done and undertaken by the most eminent scientists in our country. People go all the way to listen to them, but this is a humble effort of National Academy of Medical Sciences. that we are trying to reach each and everyone through this particular CME activity. We are grateful to All India Institute of Medical Sciences, New Delhi, who have been actively and supporting us. We had earlier few sessions from AIIMS Rishikesh also, and Professor Meenu Singh, Director AIIMS, has been very kind enough to extend us all the support and request their faculty also to contribute in these same activities. With these few words, I again welcome all of you to the AIIMS-NAMS Navigate program, and I request Professor Sareen to kindly address and bless all the as well as the participants. Over to you, sir.
Thank you, Dr. Kapil. And thanks, Dr. Meenu Singh, for taking this onus on you and the AIIMS Rishikesh. We are very thankful to you because the topic is on evidence-based medicine. We all practice as doctors, but we do not sometimes adhere to evidence, and we try to overlook them. This is a session which is not only for students, but I guess also for all of us, faculty and teachers. So we need to practice evidence-based medicine. I would like to add few things. NAMS, as Professor Kapil has said, initiated the Navigate Medico is to give a good direction, but NAMS has also activities which your students today can take benefit. And that is, NAMS has started now an associate membership. NAMS has 4 categories, people who join: NAMS Fellow, which is the topmost, then a NAMS Member, then an Associate Fellow. An Associate Fellow is anybody who has done DM or MCH and 3 years has shown some research experience, publications, can be an Associate Fellow. And NAMS Member, Associate Member can be anybody who has done MD, MS or post-graduation can become an Associate Member. The advantages are you get journal, you are able to listen to all the CMEs and can grow in an environment of best of the kind of medical people in the country. So I request you, Dr. Meenu Singh and other AIIMS functionaries to request your students to learn about NAMS, join NAMS as an associate fellow or as an associate, and for the faculty members as NAMS member or NAMS fellows. With this, I would like to also put on record that NAMS has a ongoing activity where quiz is being developed, and Preeti, who is there with Dr. Kapil, also helps in the national quiz. I request some of the quiz for the medical students which can be or faculty can be developed at the prestigious AIIMS Rishikesh, and also that a one day women in medicine can be developed as a single theme by Dr. Meenu Singh. With that, I would like to now hand over to her for introducing the topic and the speakers. Thank you so much, Dr. Meenu.
Thank you, sir. I would now like to request the IT team to display the message from Professor Srinivas sir, the Director of the All India Institute of Medical Sciences, New Delhi, related to the AIIMS-NAMS Joint Navigate Medico.
ये आवाज नहीं आ रहा है.
Remains a scope for improvement. Namaskar. At the outset, I congratulate the team behind the NAMS AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Thank you, sir. It's a honor and a privilege to invite the speaker for today's session, Professor Meenu Singh ma'am, who is the Executive Director and CEO of AIIMS Rishikesh. Dr. Meenu Singh was trained as a pediatric pulmonologist at the Children's Hospital at University of Pittsburgh, USA, 1994 to 95. Since then, she has consistently worked in India in the field of pediatric pulmonology at the Advanced Pediatric Centers at PGIMER, Chandigarh. She has more than 300 publications to her credit. Ma'am was the head of the Telemedicine Center, now designated as the Department of Telemedicine at PGIMER. She was in charge of the Regional Resource Center and National Knowledge Network at PGIMER, Chandigarh. Dr. Singh is a member of the Steering Coordination Committee for Telemedicine and E-Learning of Ministry of Health and Family Welfare. She has been a pioneer in evidence-based child health and was instrumental in the development of advanced research in evidence-based child health at PGI. A regional resource center and a center for excellence in artificial intelligence has also been started in AIIMS Rishikesh. She is also the co-chair of Cochrane India Network. Ma'am has been bestowed with many honors, awards, and medals such as Ken Warren Prize, Bharat Ratna, Dr. Abdul Kalam Gold Medal, Award of Excellence, Literary Excellence Award, and ST Achar Award. It's a honor and a privilege to have you here with us. Thank you for accepting and joining us here. Over to you, ma'am. Yes, ma'am. Over to you, ma'am.
Thank you very much, ma'am, for your kind introduction. And I would like Professor Praveen, Honorable President of National Academy of Medical Sciences, Professor Kapila, Company Secretary, Professor Ajay Sood. I would like to share my slides. I'm going to be talking about evidence-based medicine, and we'll be sharing with all the participants a few concepts which have come up over the last 20 years or so about this particular new paradigm which was applied to the medicine, which earlier was more like experience-based medicine. Can you make it slide, please? So the objectives for this session are, you have to make it slide. The objectives of this session are to increase the understanding of what evidence-based medicine involves and to share with you the principles of evidence-based medicine. We're sharing the presentation again. Okay.
Ma'am, we cannot see the slides, ma'am.
Yes, we're sharing it again. Can you see now?
Yes, ma'am.
Okay. Okay, next one. So this is, today we are trying to increase the understanding of what evidence-based medicine involves. We'll review some steps in evidence-based medicine and we'll experience some evidence-based clinical practice. So what is evidence-based medicine? It is the definition which has been derived from McMaster University is that it is the science of turning clinical problems into research questions. And then after a research question has been formulated, then this leads to accessing, then appraising, applying and auditing evidence from scientific research findings to solve clinical problems. What all these steps would involve is something which we will be sharing later on. Now, this is, a problem which we have been facing all the time. What should we do with all the research which has been happening with us? What to do with all the research which is there? We know that there are so many research agencies, and National Academy of Medical Sciences just stays close to the Indian Council of Medical Research, and we know so much research which takes place, but what happens to that research? A large number of this research may be published and later on forgotten. And sometimes there would be some research which is published, but again, which is not worth taking into practice. So there are several steps which are lost in between when we have this paradigm of research to practice or evidence to practice. Next one. I would just like to ask all of you to just stay for 5 seconds and think of these questions. The first is, what did you first hear about evidence-based medicine and then? This will give you some idea of, we know that there are very senior people who are with us today. They would have heard about evidence-based medicine long time ago when it started, people started talking about it. And of course, there were clinicians who were always evidence-based, who would do research themselves and compare their research with others, and then take whatever was the best message. So probably they were already practicing evidence-based medicine. But then people started talking about this particular paradigm in a very strong way somewhere in the 90s, when it was thought that we are not taking into account most of the research which has already happened or published, and we should seriously think about it and access this research, critically appraise it, and take it to practice. The second question which I want you to think about is, what do you think it involves? There are many residents who have joined today and many students who would have heard about evidence-based medicine, but they would probably think that, okay, it is just like reading a journal article and being aware of what's been happening, and that is all it is. But actually, it is not that. There are several steps which have to be followed, and we have to be very knowledgeable, and we should be also able to use that knowledge in practice. That is what it would involve. And then, have you changed your mind? Has this practice of EBM actually changed your mind? That is the most important question, because many times we know what works. We also know that if it works, if it is taken to the patient, it will benefit them. But still, we don't do it because there are so many factors which determine its turning into practice. So that's also a very important question as to how we change our minds to practice evidence-based medicine. Now, this is a slide which we show for the many people, and this is actually called the slippery slope. And what you see is that this is along the x-axis, you have the years since graduation, like this, and on the y-axis, you have knowledge of breast care. And what was seen in a systematic review was that years since graduation, as they increase, the evidence-based practice, the knowledge of current knowledge of the evidence goes on decreasing. And that is because as our age advances and as we are far from our graduation years, we stop reading, we stop being updated, and we continue to use whatever is there in our, whatever is there in our experience, and we don't update ourselves. So this was a systematic review of 62 studies, and 94% of those studies have found that there is a decreasing competence for at least some tasks with increasing age. But then, came technology, and all of us, including those who were beyond the years of learning according to this particular systematic review, everybody became updated because we got the power in our hands, that is in the computers as well as in the mobile phones. You can access literature, you can access databases, and you can actually start practicing what is known as evidence-based medicine. Now, this is the evidence-based practice timeline, which we usually like to show to the junior people. And this is Archie Cochrane, who was a British epidemiologist, and after whose name is this Cochrane collaboration and the Cochrane Library, which is now like a journal, which is an electronic journal with an impact factor of 16. And so Archie Cochrane thought, and he wrote a book, he called Random Reflections on Health Services. And what he lamented about was that we were not making use of all the results of the trials which were already available, and we were not changing our practices. And that made people think, and there were a few people who got together and then established the Cochrane collaboration, which was established somewhere in 1993. But for so many years, all this knowledge which had been written about by Archie Cochrane was not utilized to a large extent. And of course, there was Dave Sackett, who was a professor of clinical epidemiology at Masters as well as he taught at Oxford. And he's the one who gave this, the definition that it is a science of turning clinical problems into research questions, and then the 4 days that you need to access, appraise, and apply this knowledge and audit the knowledge which has been gathered. Then another picture is that of Gordon Guyatt, who is prof at Masters University, and in 1985, actually, Dave Sackett had written this book called Clinical Epidemiology, which has all this definition and various concepts which have gone to the evidence-based medicine. So Gordon Guyatt actually is the person, he's a professor in McMaster University, and he's the one who's given this term called evidence-based medicine. So in English, of course, it is evidence-based medicine, and sometimes we try to translate into Hindi, so we call it Sakshay Adharit Chikitsa. That means something which is based on clinical evidence and research evidence which comes from doing studies and publishing them and critically assessing them. So a book called A Guide to Effective Care in Pregnancy and Childbirth was written somewhere in 1989. And this was a book in which, again, these concepts were applied to maternal and child care. And there was Sir Ian Chalmers, who is a British obstetric and gynecologist. Of course, now he's Sir Ian Chalmers, and he has actually been a great force in establishing Cochrane collaboration. And they started this perinatal database of systematic reviews or Cochrane reviews, which was published by Update Software in Oxford University. And later on, this is what was converted into the Cochrane Library. Then several centers of evidence-based practice were established around the world, and many of them were actually Cochrane centers, because most of the countries who were convinced and were familiar with the concept of Cochrane They established the centers which were called Cochrane centers, but then other centers of evidence-based practice were also established. For example, in McMaster University. And in India, we started talking about all this somewhere in 2000s, early 2000s, when we had a collaboration with Royal College of Pediatrics and Childcare, which was with the Indian Academy of Pediatrics. And we started doing courses for pediatricians and for other people also, because I do remember Professor Ramalinda Swami once I was interviewed by him, and he grilled me on this evidence-based medicine. So, so this was a concept which was there with a lot of people, and then there was establishment of an Indian South Asian Cochrane network, which was based in Vellore, and several other people, including Pakistan, Bangladesh, Sri Lanka, they were associated with this. Chandigarh PGI was one of the sites, and we were continuing to do that. And we also established ICMR Advanced Center for Evidence-Based Childhood somewhere in 2012, which is still running. And in Rishikesh, we started the Center for Evidence Synthesis and Public Policy, because we found that there were a lot of takers from policy who wanted to have evidence. And this is what we are doing here in Rishikesh right now, working with ICMR and EPIO for advising policy at times. So Cochrane centers were established around the world, and in 2022 October, we had Indian Cochrane Network, which is a network of 9 affiliates, which includes All India Institute of Medical Sciences Delhi, PGI Chandigarh, CME Vellore, and Tata Memorial Hospital, and some more institutions were there as this Cochrane network. So this was another book which was written and is read about by pediatricians, which is evidence-based pediatrics and child health. And this was done by the team which used to come with us and do the teaching. Then somewhere in the 2010s started the patient involvement in decisions. And even now, patients who are called consumers have become stakeholders in making decisions about themselves, and they refer to evidence in their deliberations whenever they are there. Now, there are systems to support evidence-based practice, and one of these is like there is something which is like a pre-appraised evidence, which is in the form of systematic reviews. These are outcome of carrying out an evidence-based practice in the form of formulating a question, then accessing literature, then critically appraising it, then meta-analyzing it. So all that comes in systematic reviews, and as you know, Cochrane Library is one very rich document in which publishes systematic reviews, which are called Cochrane reviews. Then we have evidence synthesis, for example, clinical evidence, which is also a database. Then the guidelines, which are published by several societies. And I wish even National Academy of Medical Sciences could take up the job of formulating guidelines, which at the moment is being done by Department of Health Research. But I think it is something which goes with the clinical practice, and as it goes on, as the clinical practice goes on changing, these guidelines also need to become living guidelines. Then there are evidence synopses. For example, there are EBM journals. There are several journals now which are based on evidence-based medicine, which come up. But along with this, we also need to have web access to publication databases, which are like Time, PubMed, Embase, Cochrane. So all these also are now needed if you want to really access literature, everything which is there about every problem. So we need to have access to these. We have electronic journals. We know that we have a very rich National Medical Library, which is subscribing to all kinds of databases. All Indian Institutes of Medical Sciences have rich libraries, which should be, I think, interlinked for all the medical colleges, because there are so many new medical colleges which have come up, and it will be very economical if we start using these resources which are present in central institutions through some platform. So there is something else which is important, and that is getting others to use the evidence in practice. So we always ask the question, what have you seen that worked well? And How have you derived that when once you start thinking about it? So for that purpose, what works in evidence-based practice, that means how students become aware of evidence-based medicine and evidence-based practice, the best approach is interactive and it should be a clinically integrated teaching. That means if you want to teach about evidence-based medicine, it is something which should be based on clinical problems which arise day to day on ward rounds or in emergencies when the patients are being managed, and also in small group interactive teaching, and many times journal clubs, which should be at least small group in which people are trying to understand whatever is there in a particular paper. And so there is this article actually had objectively tested that ward rounds, journal clubs, clinical teaching and assessment, outpatient clinics, formal clinical meetings and audits. What was it which was helping in different steps of evidence-based medicine the most? We know that 3+ is the maximum opportunity and 1+ was that the opportunity was hardly there. So it was seen that formulating questions was something which came up mostly in the outpatient clinics and ward rounds, and also in formal clinical meetings. Like when we have a clinical meeting about a case, at the end of it, there are so many questions which are there, which need to be answered, and those questions actually become food for research. Then in searching for evidence, of course, you're doing only searches. And in critical appraisal, it is a journal club which actually does the maximum critical appraisal. That means it really needs reading of the article and underlining, the various components which have been there, analyzed, said there, whatever has been projected in that particular article. Then about integrating evidence with clinical scenario is also very important, and that is also possible in ward rounds. It is also possible in clinical teaching and assessment and outpatient clinics. So that integration is actually very, very important, and that is what is to be learned by the teachers. And I think we also need to do some courses. We do some courses about how to practice evidence-based medicine, and we also do courses on how to teach evidence-based practice. So that is something which we have been continuing to do. And then bringing change to practice is something which is very difficult, but that happens when you do clinical audit. That means if there has been an adverse outcome and you ask questions, or if you look at your data again, and that is the time which really teaches the people that they needed to do this and not that, which they had, the choice which they had taken for treating a particular patient, whether that is correct or not correct. That comes only when you are discussing these cases after the students have been. So now, what are the steps in evidence-based medicine? As we said, that the first step is the clinical problem, and that means that we need to think, what are we talking about? We may be talking about respiratory disease, maybe we may be talking about liver disease. So in that also we know what disease we are talking about, and in that disease also what are we talking about? Is it intervention? Is it treatment? Is it diagnosis? Is it prognosis? So the first thing which we need to know in evidence-based medicine is to admit uncertainty. That means the question that is to be asked doesn't have an answer already. Because if you have an answer, then there is no point in doing further research on that. So we need to pick up questions which are about which we are uncertain. And what we have found is that most questions which we think we know the answers, there would certainly be some questions which will arise out of them. Then after this focused question, we would go to search the literature. And we know that these days searching literature has become much easier. Earlier we had to do it on Index Medicus or current contents and all the databases, etc. Medica. But now we have electronic databases. We have PubMed, we have MBase, we have Cochrane, we have EBSCO. There are so many platforms on which these databases are available. All you need to know is how to search them. But that also is a specialty now, and we are seeing the breed of librarians, which are called evidence-based librarians. And I could see in the list of participants, there was Mr. Medico, who is to help us in PGI with evidence-based searching. So we need to have more of these librarians who know how to do electronic searches on different databases And they also split up these questions into the TICO format, which are becoming and base their search on that particular format. And then come out with a reproducible search strategy. That means if you have done that search at one point using the various Boolean operators and all the terms and putting limits, and there is something which is known as clinical queries in PubMed, which is very evidence-rich and takes you directly to systematic and control trials. So we all need to know these tricks, how to find the best literature, and those tricks are taught to us by the evidence-based language. The next thing is, after we have searched the literature and we have a bag full of articles, say 1,000 articles about a particular intervention in a particular problem, the next thing is to shortlist some of these articles which are based on our inclusion and exclusion criteria. And from those, the ones which get included after we have conducted a kind of initial survey of the abstracts of these papers, we would like to appraise their quality. And there are different tools of critical appraisal which are available. And on the basis of that, we can say, okay, this article is good. This is something which meets our criteria. This can be included into a systematic review, and that kind of decision which can be made, which is based on an appraised article, and then we evaluate later on, these articles, and then try to see whether we are really going to take it into practice or not. So after all this work which is done by the doers of evidence-based medicine. Doers means people who are doing systematic, who are looking into these various points, and they are kind of technical experts, methods experts, who would be able to tell us ultimately that this is what has to be done. But the second group is the users. That means people who would use evidence which has been generated. And although these days we have guidelines, and most of the guidelines will tend to be evidence-based, but there are some consensus-based guidelines also. And users, if they are exposed to those practices, they tend to use them better. So it's also very important that we co-opt them as members of our team, and somehow we disseminate the guidelines in such a way that the users become familiar with them, and they also become kind of aware that if they use these guidelines, the patients are going to have better outcomes. Now, these framing of answerable questions could be of different types. The questions could be, they could be intervention. For example, say if we take example of bronchial asthma, what intervention, whether great corticosteroids are a good intervention for them. It could be diagnosis, which could be, say, for bronchial asthma, if we want to diagnose it, what kind of test should be done, whether we need to do spirometry, whether we need to do something else, whether we need to do bronchial challenges. So diagnosis can be another field in which systematic reviews can be done based on the diagnostic test. Then there are things about causation. What is causing a particular condition? And we know that in non-communicable diseases, there's a whole lot of risk factors which are taken into account when we think of causation of disease. For example, say air pollution, whether it really leads to increased incidence of respiratory infections, whether it leads to increased incidence of bronchial asthma, that is something which is causation and will be linked to it. So there is something like cause and effect, and that can be taken up in this particular article. And then we have prognosis, which is also based on factors. There are prognostic factors. So we mostly need to have models which are based on, say, linear regression or multiple regression, and various models which have come up now with the AI tools which help us in performing some of these analyses, which earlier were limited to some software. And as computational analysis is increasing, we are having better tools and more sensitive and effective tools in carrying out some of these analyses. But then we need to know what we are doing, what kind of question we are asking. So we need to, because the methodology will be ultimately based on the type of question you prepare. How to qualitatively assess a particular study will be based on the tools which are available, and that is a very practical kind of situation. So every question is actually broken into these parts, and this is called PICO, which is also these are four components, and this is the fifth dimension, which is time. And so P is in PICO, P is patient population, the problem which is there, the patients who are suffering from that problem. For example, children with bronchial asthma is the patient population. Then we have the intervention or exposure. So for an interventional study, it would be an intervention, for example, an intervention of, say, humidification therapy for respiratory infections, or it could be just exposure, for example, a person's exposure to COVID virus. That means a cohort of patients who have suffered from COVID disease and they are being followed, and we want to see what kind of illnesses they are coming out with. Similarly, people who are exposed to air pollution, we need to see whether they are suffering from increased respiratory infections alone, or they're also having hypertension or other non-communicable diseases like cancers. Of course, they get lung cancer as well. Then is the comparator. C is for comparator. Comparator means the group which is not exposed either to intervention or it is not exposed to the exposed risk which we are thinking about, because we can take, say, people from another area who are not exposed to a particular kind of offending agent, that could be taken under control. So comparison is also can also be for a control. For example, in a randomized control trial, you have a group which is intervention group and the second group which is a control group. So there also is I is intervention and C is comparison. Then is the outcome. It's in a question. It is very important. What are we trying to see? What are we trying to see after an intervention? How is that intervention going to change the outcome of a particular patient, whether it is related to some measurable outcome, for example, spirometry, or for liver functions, or for nutritional outcomes. We can see how much is, say, iron supplementation going to increase the hemoglobin in a patient. So different methods of iron supplementation, how effective they are in correcting anemia. So that degree of change from the baseline sometimes becomes outcome. And that degree nowadays, people are not just measuring these objective parameters, biochemical parameters, or experimental parameters, they're also talking about quality of life, which is a little bit subjective. And sometimes we have to use some qualitative methods also in conducting our studies. And now there is a whole lot of methodology which is available for even categorizing qualitative studies and doing systematic reviews for that. Then is the time. We know that how much should be the duration for which a patient has to be followed. For example, in randomized controlled trials, which are usually short, which would not last more than 1 or 2 years, we don't know what happens to the patients later on. So time becomes a very important factor when we want to see the, the side effects of particular interventions. And for exposures, of course, it is a slow effect, which is there, say, for environmental pollution, effect of plastics, and other things which would affect human health. That takes a very long time. And that is why we need to have long time cohort studies to answer those type of questions. And of course, we have tools in which we can critically appraise cohort studies as well. Okay, so let us come to a question in which the step 2 of evidence-based practice after the PICO has been done. So how do we search literature? So first of all, supposing we have a question like which toothbrush works better, it is manual or electric. We know that children are, very fond of using electric. Many people are very fond of using electric toothbrushes. We don't really know whether the manual toothbrush should be used. I mean, this is a question which is of great interest to the dentists. And so which toothbrush is better, works better? So if you go to PubMed and you start looking at the studies, you will select some of these terms which are there. And as I told you earlier, clinical queries is one database which is found on the left side of the PubMed menu. And if you click on that, then you find that you would select therapy, and then you find you write the Boolean operators like or and asterisk. And then you will find that you find something like 135 studies, you find about 42 systematic reviews. So this is, the knowledge which comes to hand when you have search literature. And then maybe you would not like to do a systematic review, you would like to do an overview of all these systematic reviews and then come out with some conclusion. So we have come to a focus question with search literature, and after we get these studies, we have to critically appraise them, and we have to find the merits in those particular studies which are there, and then evaluate them. Next one, please. And ultimately, we find what is known as educational prescription. That means this educational prescription could be for the physicians or the dentists who have to apply these findings to their patients. And here, to write the patient's name or the learner's name, we could write the target disorder. We could write what is the intervention, what was the outcome, and what is this education prescription based on? For example, the search strategy, the search results, the validity of the evidence, the importance of this valid evidence, and can this valid, important evidence be applied to your patient? And then your evaluation of this particular process. So this is also something which can be introduced in our clinical teaching as an education practice. So this I have already shown. So I just give you an example of, and many of the students who are there, they may not have they have never critically appraised the systematic review. So you are aware that patients of acute asthma are usually given nebulization, and there was a systematic review which was based on randomized controlled trials, which showed that holding chambers, you can either use spacers. Now we know that we can use spacers also in acute setting of bronchial asthma along versus nebulizers. And because beta agonist is the treatment of acute asthma, of course, at least the initial treatment. Next one. So here the objective was to assess the effect of holding chambers, that is spacers. So this was the test intervention compared to nebulizers, which is the standard therapy for delivery of beta-2 agonists for acute asthma. So the selection criteria here would be the authors thought that they should be taking up randomized trials in adults and children, and children they defined from 2 years of age, where spacers of beta agonists could be spacers for the use of beta agonists could be compared with wet nebulization. Next one. So electronic searching was done, and they found 112 abstracts, from which 44 were selected for possible inclusion. In agreement between the two independent assessments, for example, one person can be biased. So you need to expose these results which you get to more than one person, and you can do for kappa statistics. That means your inter-observer variation can be measured, and again decide about the significance of what kappa you will take as significant. And these studies which are there, they are then critically appraised based on a risk of bias tool. It is called ROB tool, and you can see that there were so many studies. If the study, so the things which was whether there was adequate sequence generation, there was allocation of treatment, or what was whether the blinding was done or not. And these red, green, and yellow dots which are there. The red means that it wasn't done properly. Green means yes, this was done properly, and yellow means that you don't know because you are uncertain about it. So ultimately, there is this tool estimates what is the risk of bias which is present in a particular study, and that is what gets reflected in the systematic review also. And these days, after a systematic review is done, we do what is known as grade. We do the grading of recommendations of the evidence, and there this risk of bias will again becomes very, very important. So this is what is known as the forest plot. Why forest plot? Because if you have all these branches which are there, and if these lines which are there, if they are thought to be trees, then it kind of looks like a forest. It's just somebody's imagination. And here you can see that in adults, what they found, and the results were based only on 2 studies, that the spacers and nebulizers. So on this side, it was that the holding chamber is better. On this side, it is that the nebulizer is better. So what you can see is that none of these results which are there, which are crossing this zero line, which is known as the line of no effect. So most of these two studies and this diamond, which is the result of these two, or the pooled effect of these two, is on either side. It is on line of uncertainty. So that means the results were uncertain in that eye. But as far as children were concerned, where the results were based on these three studies, and the total was about 196 plus 200, 200 participants. And it was seen that here the results were favoring the chambers. That means holding chambers or spacers were better than nebulizers in treatment of acute episode of asthma with beta. So in duration, then they also looked at other outcomes, and that was that the duration in emergency room in children was significantly shorter with spacers in comparison to the nebulizer, and this was based on the results of three studies with 427 participants. There is another study which is very often cited and which has actually changed practice throughout the world, and that is of administration of corticosteroids to antenatal mothers to prevent respiratory distress syndrome or silent member disease. We know that a large number of newborn babies die of respiratory distress, but if these and that results as a because of premature rupture of membranes or leaking peritoneum, and these mothers are now it's a standard practice that they should be given steroids, but at that time nobody knew that this is going to work. So a number of studies had been done, and this was a meta-analysis. It is a very landmark meta-analysis which showed that the total effect, actually what it showed was that administration of corticosteroids versus placebo led to improvement, and it led to about 50% reduction in the mortality or the outcomes which were being considered in the occurrence of or incidence of respiratory distress syndrome in these patients. But once we looked at babies who were born in less than 22 weeks, there were very few studies. So this was like a subgroup analysis. So at this point of time, it was unclear whether this intervention works very well. And that is the reason here was that there were only two studies and the sample size was really small. So the main idea of meta-analysis is that you tend to increase the sample size and then your results become more coherent, they become more impactful, and the effectiveness can be tested in a much better way. So here you can think of what should be the PICO for these patients. The patient population here is antenatal mothers who are undergoing premature delivery. The intervention here is administration of corticosteroids. The comparator here was the placebo, and the outcome was there. What was the incidence of respiratory distress syndrome? It could also be mortality. It could also be incidence of interventricular hemorrhage. So patient population also needs to be better defined sometimes. It could happen at 34 weeks, where the baseline risk of developing respiratory distress syndrome may not be as high as it is at 26 weeks when the babies are much more premature. So the intervention, of course, will work. And so we need to estimate the baseline risk of respiratory distress syndrome at 26 weeks or 34 weeks. And if we find that if there are 100 babies and 100 mothers to whom we have given antenatal steroids, and if their baseline risk of developing respiratory distress syndrome was, say, 40%, that means 40 children who have been born develop respiratory distress syndrome. But if after intervention we find that only 20 of them are developing, that means there is a 50% reduction, absolute reduction in the development of respiratory distress syndrome. So that would be the absolute risk difference between the treated and the untreated groups. And this 50% would mean that if you expose 100 divided by 50 would be what we call as the number needed to treat. That means if you treat two mothers, at least one you would have prevented the respiratory occurrence of respiratory distress syndrome. So this is kind of giving a statistical value, a mathematical value to the thought which has come out. and would determine the clinical significance. If it was something like out of 50, only one baby is going to benefit, or only one mother is going to lead to less baby with distress syndrome, then the efficacy of that treatment was not that much as it is when the number needed to treat is smaller. That means number needed to treat here was 2. So this is how we determine the value of what findings we have got. And that is what, this logo of Cochrane collaboration is actually based on this study, which has been shown to you just now. And this review was done by Patricia Crowley, and these were the various, these studies which were there. And this is a diamond which gave the net result that giving corticosteroids helps in prevention of respiratory distress syndrome. And these 2 seals which are there, that is for Cochrane collaboration. And this is actually a registered trademark of Cochrane collaboration, this logo which is there. And currently, of course, we in India also are using it for Cochrane India. Next. So the next point is that after an evidence has come up, so of course, asking questions means pulling in evidence. That means we start doing systematic reviews, we start thinking about those questions, we research literature and practices that we talk about. But then there is also something about pushing evidence that is into the practitioners, that is by using guidelines, that we need to make guidelines after an evidence has been obtained. And at present, I think there is a whole lot of evidence, but there are a whole lot of guidelines also, which also now need to be graded and found whether they are evidence-based or not. Next. So there is something which also helps us in determining what evidence has, what is the role of evidence in particular practice, and we are going to show you a Venn diagram. So on one side, you have this clinical state and circumstances. On the other side, we have patients' preferences and actions, and then we have research evidence. So actually, it is these 3 things which lead to clinical expertise, and this is how we apply evidence to our patients. Next. And along with that, we also have now a concept which is coming in, which is based on all the 3 tenets which are there. And that is what is known as the value-based medicine. Recently, I had an occasion to attend the 30th Cochrane Colloquium of London, and there some of the people who had started Cochrane collaboration, they are now talking about value-based medicine, that it is not all evidence which would help in good practice. It would also be, sometimes the patient may not like a particular therapy. The patient may not be able to afford a particular therapy. So you have to give importance to patients' preferences and actions. And sometimes the clinical state and circumstances are such. For example, if it's a 90-year-old patient and it's a very expensive treatment and the patient has developed cancer and will give only a few extra months of life, you may not like to choose that particular therapy. So value judgment also becomes extremely important, and we really need to know how to practice evidence-based medicine. And there, I think some experience also comes into action. And it is only not just mathematical figures, it is also your wisdom, which is extremely important to you. Next one. So I would just end with this saying by Elias that where is the wisdom? We have lost in knowledge. We have a lot of knowledge, but we kind of losing wisdom and the knowledge in information. We have a lot of information on Google. We have a lot of information in all other databases. We have artificial intelligence now, which has come in, which will give us clinical decision support systems. But if they are not wise enough, we would be in for trouble. So I think with that, I will end my lecture today, and I'm open to any questions. So I think the questions can be posted in the chat box.
Can I ask a question, Dr. Meenu Singh? do we have a survey or a assessment of how many people are following what you have said? Let's say we can do it in all AIIMS or otherwise, that a simple 5 questions. Are you aware of this? Are you following? Are you updating yourself? Blah, blah, blah. So I was thinking, just from a common perspective, everyone says I know, but I learned a lot today. So I just thought you can have a small survey if you like.
So there is no study, as you know already, there is no study. We can do a study or a survey which is based on a large sample size. Although in small groups, we have been doing a pre-test and post-test, and we try to see that the knowledge which is there in the beginning was less and later on it will increase. But what is happening on the ground is something which we really don't know. And I think you're very right. If we do that kind of a survey, we would know that we need to include this in our medical curriculum. We need to have this kind of lectures going on or interaction even for medical graduates. So that will become a
Thank you. Thank you on from my side, and I hope there will be other questions.
We're not finding many questions, at least in the chat box. We can just extend our conversation on this particular point if you want. So I think the steps which we can take up at the national level is that we know that there are very few centers which have these centers for evidence-based practice. And in our AIIMS CIB meetings, when we have these Central Institute body meetings and we have Chintan Shivers, that is where it has been proposed that for at least for AIIMS, every AIIMS should have a center for evidence synthesis. And this center should take up the responsibility of capacity building, along with doing some systematic review, and those can be divided into different categories by different institutes. They should be locally appropriate and applicable, the questions which they take up. And then we can also participate in formulating some national guidelines, which are, which come from many of the experts which are there in that particular field. So that kind of agenda has been there. And currently, since I'm also part of the Cochrane India network and looking after it, along with Dr. Anju Sinha, who's in ICMR as co-chair, and Cochrane also is now changing its format, and many people who want to get into this the mainstream of doing Cochrane reviews or systematic reviews, it's become very important that we start reading the literature which has come up. There was something which was known as the Cochrane Handbook, which gives all the information about how to do a systematic review, what software to use, how to use it, and what is great, because that is another system which tends to analyze the quality of evidence. So all these tools actually have now become available, and evidence-based medicine by itself has become a discipline now, in which people are trying to take qualifications. And they have a MSc in Master's University. We also try to start an MSc in PDET and for evidence-based practice, but haven't been started so far. So some centralized courses, I think, can be started by National Academy of Medical Sciences in the field of evidence-based practice and evidence-based medicine. Because doing a systematic, creating a guideline is one thing, but making it being followed by the practitioners is another point. And this is what is known as translation, knowledge translation. And research in knowledge translation also can be promoted by the academy.
questions by the participants?
So we are not finding much any questions. I hope.
If there are no more questions, can we like conclude now, if it is okay with you? Or do you want to ask any questions to the audience?
Audience can raise their hand. I mean, we can just ask them questions whether they've really heard about evidence-based medicine or not. Or how did they like the lecture? Would they like to have any improvement? Or, a different way in which we can drive the point home better. So that is why, sometimes in these kind of talks, interaction is something has to be there.
Dr. Divya Gupta from Dehradun has mentioned, ma'am, very informative talk. Would just like to know more about medicine from you, ma'am.
Yes, we are doing courses and you're not far away. There are very close to the stage. We can have attend some of these courses. There is a very interesting part of the Cochrane website, which is called Cochrane Training, and there you have many webinars which are there, which one can initially go through, because all the steps of doing systematic reviews and practicing evidence-based medicine are also available. We had another website which was called which is Sakshi Adharit Chikitsa, which we have created as a center for AIIMS, Center for Evidence-Based Practice. There also we have the products together. And I'm sure the series of lectures which have been there on, we can have more lectures on this particular theme. And this YouTube channel and NAMS website which is there, we can populate these lectures onto that. Okay.
Thank you, ma'am. It was a very informative lecture. Thank you for sparing your time for this wonderful webinar, ma'am. Now I'd like to request Professor Ajay Kumar Sood, sir, the Deputy Secretary of National Academy of Medical Sciences, to deliver the vote of thanks.
Thank you so much. It is indeed my great pleasure to thank the distinguished speaker for this evening, Director AIIMS Rishikesh, Madam Meenu Singh. Thank you so much, Madam, for being with us and sparing your valuable time. I'm sure that the points which you have raised in this session, evidence-based medicine, are very, very important, especially for the PG students when they are doing their cases and also for the clinical practice. Thank you so much for your support to the National Academy of Medical Sciences, and we look forward for a blessing in future also. Thank you. I will also place on. Thank you. I will also like to place on record the support director, deans, faculty member, HODs of various AIIMS, and with your support, we have been able to sort of carry this CME program forward. We have more than 1,000 PG students registered. But again, I appeal that we require your further support. This is your own program, so kindly give suggestion for future topics and also come forward for taking this session. So this is my humble request to all the faculty members from AIIMS. Thank you so much.
One question is that we can create a group, a web group, on which we can circulate this topic to all the nodal officers or somebody in AIIMS, different AIIMS, because sometimes directors don't have that much time. So we can ask the people who are designated to carry out these activities in all 22 AIIMS, that they can circulate these.
Sure. Thank you so much.
It's something we didn't get it done.
I would like to also thank the participants who were with us this evening. And again, I want to appeal that this is your own program, especially the PG student, they should come forward and can always send your question in advance so that we can put forward to the speaker. So please encourage your fellow student to join. And for your information, on 8th of December, which happens, we have another interesting session in collaboration with the Association of Physicians of India and National Academy of Medical Sciences at 7 p.m. To 8 p.m. The guest faculty from NAMS as well as from the Association of Physicians of India they are going to discuss an important topic on management of heart failure and recent advances. So there again, I think you will get the opportunity to interact with the best speaker. You can always ask your question. So I will request all the participants to join that, and we'll share the link with you very soon. Again, I would like to thank the moderator for this evening, Dr. Preeti, who has been helping us from the very beginning. Thank you so much for time and helping us. We look forward for your support in future also. In the end, I will also like to place record the support which you have from the officer, Mr. Ravi. He has been sending you emails, Zoom link, and also helping us in the transmission of this session on Zoom as well as on the YouTube. So once again, I thank you all for being with us and making this session very interesting for all of us. Thank you, madam, once again. Good night.
Thank you.
Thank you, dear. Thank you, one and all.